Welcome to After the Bell. I am your host, Lauren Cranmer, and today we have a very special guest, Dr. Elyce Cardonick. Dr. Elyce Cardonick is a high-risk obstetrician at Cooper University Healthcare and a professor of obstetrics and gynecology at Cooper Medical School of Rowan University. She specializes in the care of women who, during their pregnancy, receive a diagnosis of cancer. She's the woman behind the Cancer and Pregnancy Registry, where they research pregnant women with cancer and their children. By pooling information into a central registry, they can accumulate stronger data to help oncologists, obstetricians, and patients make informed decisions about treating cancer and pregnancy. Additionally, they help women with cancer make educated choices based on data. They support the treating physicians if desired, and they reassure patients that they aren't the first to go through this. Most importantly, Elyce is a loving mother of her children and her dogs. She is truly passionate about what she does. And lastly, she is a cancer survivor herself. So with all that being said, this woman is amazing. I have so many questions to ask her. We had a great conversation about the Cancer and Pregnancy Registry. I had some questions for her about cancer and pregnancy itself and the treatment going through, as well as her own cancer journey. She had a lot of insight to that as well. So this is a really great listen. If you are going through cancer and pregnancy right now, and that's why you're on this video, I personally am a stage 3 breast cancer while pregnant survivor. You are not alone. There are resources, there is support. Reach out to me, reach out to Dr. Cardonick and the Cancer and Pregnancy Network. That being said, help me welcome Elyce. Welcome, Dr. Cardonick. How are you doing?
I'm good, thanks. Thanks
Thank
for
you
having me.
so much for being here. I'm very excited to talk to you. You were like one of the very few angels I had at the very beginning of my own journey with pregnancy and cancer. I'll never forget when you called me after I signed up for your registry. I was kind of like all over the place because I had a ton of doctor's appointments, talking to like a bunch of people. And I was like, wait, who am I speaking to? Like, what is happening? And then when you started giving me information about the registry and kind of you like hope on how to handle this while I was pregnant, I felt like I had it was like something clicked where I'm like, I am not alone, you know? And I'll never forget that. So I just wanted to thank you first for that.
Not necessary, but I'm so
and
happy. I'm so happy to
and
hear
thank
that,
you
and
just
that's definitely the purpose of it, to make people feel they're not alone.
yeah, I never thought this was a thing, you know, cancer
Sure.
and pregnancy. So I like learning through it. I didn't realize how many people were affected by it and that there are resources, there are things we could do. So I really appreciate you coming on here to kind of shed some light on that. So why don't we talk about the registry first, kind of like what it is and how can women, if they are diagnosed with cancer while they are pregnant, how could they get into the registry?
Sure. So the purpose of the registry is to collect as many cases as possible into one location so we can see trends and we can help oncologists and patients make informed decisions. So if cancer in pregnancy occurs about 1 in 1,000 pregnancies, then statistically each oncologist may have 5 at most pregnant women in their practice, and each OBGYN may have 5 at most pregnant women who have cancer. So you can't really feel comfortable treating a patient based on the last patient you treated. You want to feel comfortable based on how hundreds of women are treated. So the purpose of the registry was to say, okay, there's 5 cases in here, and there's 10 in California, and there's 5 elsewhere, and 4, and et cetera. Let's look at all of them in one place. So not only is it to help women feel like they're not the only one going through it, and there are other women around the country and in the world who are also going through it, but to also be able to say, you're not the first one going through it, and this is how other women have done who've been treated, and this is how their children have done.
Yeah.
Because at the time that I met my first patient who was pregnant at 10 weeks with lymphoma, there was very few case reports about giving chemo in pregnancy, and of those case reports, they really didn't give a lot of detail about the baby. They did say the mom was well, and they did say that the mom's 5-year survival was very similar to how her survival would have been if she weren't pregnant. But the only detail about the newborns was normal at birth. And as an OBGYN, a high-risk doctor, I knew that even though the fetus was not exposed to chemo in the first 12 weeks when the organs are developing, the brain and the heart and everything continues to develop throughout the pregnancy. So what happens after birth, looking at the child at birth to say there's no birth defects is not enough. You have to know if they're walking on time and talking on time and meeting developmental milestones. That's what women want to know. So that's the other purpose of the registry, is to follow these children long term after birth and make sure they're meeting milestones. So that if an oncologist calls and says, I have a patient with breast cancer, I've never given Adriamycin cytoxan in pregnancy, what's your experience? We can say, well, there's 350 women in the registry diagnosed with breast cancer, and 210 of their children have been exposed to AC. This is their mean birth weight. They were able to get close to term. Of those women, this is how many additionally had Taxol, and then be able to say how the moms and baby did, so that that oncologist also doesn't feel like the first person to ever give chemo in pregnancy.
Yeah, I remember having you, while you weren't my doctor, you spoke to my oncologist and spoke about my care and had information in regards to what people have done before and what works, even in regards to the baby and the drugs that I'd be taking along with chemo. And that was a game changer, and it was life changing, obviously. And even for me and my oncologist, going forward with treatment, it was just it was amazing, because it's like my oncologist personally never had a patient who was pregnant with cancer. So I felt kind of, I was just like out there, like floating. And then he was able to communicate with you, which was, I'm so grateful for that as well. Um, with that information, I think that's insanely important to get out there, which is why I want to talk to you,
And then the other purpose is that, I see women with high risk medical problems. So I have women that come in with severe anxiety and depression who've stopped their antidepressants, or someone with high blood pressure who stopped their blood pressure meds, someone with seizure medication who stopped their seizure meds and then has a seizure. And the poor woman with anxiety, I came in, she was literally in the fetal position on my office floor. She couldn't cope. So women in general say, "Oh, I'm not going to do anything that's for my own health. I'm going to do everything to have a healthy baby and stop any medication." And cancer, hypertension, seizures, everything, you have to realize that if you don't keep the mom healthy, you're not helping the fetus either. So
Right.
taking care of herself, taking that medication for her anxiety and her depression or her seizures is having her be healthy, which helps grow a healthy pregnancy. And that's the other point, that we don't want women. There's sad cases I know of where women hid a lump from their partners and their doctors because they thought they would be advised to terminate. And at
Yeah.
the C-section, literally at the delivery, they said, "Doctor, I've had this breast mass my whole pregnancy. I didn't want to show you." And then the woman died when the baby was a year old. So it's not about doing everything to protect the fetus. It's about doing everything to protect the mother baby unit. And
Yeah.
that means you treat the mom as best as you can. Now, if we have a slow growing tumor and it's someone's 28 weeks and the doctor says to me, "I think that if we don't treat her for the next 12 weeks, nothing's going to change her prognosis," of course we won't give chemotherapy or do things in pregnancy we don't need to do. But if the treatment were to be, if we don't give chemo or surgery or this treatment in a timely manner, it's not going to do well for the mom in the long run, then that's not what we want to do in pregnancy.
Right. Absolutely. Now, what are there any specific cancers or specific treatments that are absolutely not allowed in pregnancy?
So there's always exceptions. Like we can say, okay, we don't do radiation in pregnancy, but we do radiation for brain tumors. We do radiation sometimes for thyroid tumors because the location of those tumors are far from your uterus and your pelvis where
Right.
your baby is. So methotrexate we don't use in pregnancy. That's a chemotherapy drug that
Right.
we would choose not to use. I always say, not to use the newest medication on the block. So if there's a new anthracycline chemotherapy that comes out, similar to Adriamycin, even though that might be used in non-pregnant patients, I would still prefer to use the medication that's still working for breast cancer but has more experience in pregnancy. So you're not
Right.
going to use the newest one. And, if we have this conversation, you and I, 5 years from now, it might be different about immunotherapy, but currently there's not a lot of information on immunotherapy. Right?
Right.
So I would say probably radiation, methotrexate are the main contraindications. Idarubicin I would not use. It is a type of anthracycline, but it crosses the placenta more easily, so I wouldn't use that. And, even immunotherapy, I can't say that's an absolute because for metastatic melanoma, for which we have no other therapy, um, we would give immunotherapy. Lung cancer, for which we have nothing else to offer, we would give immunotherapy. So, yeah, it changes again, and there's registries to collect if someone is exposed to immunotherapy and becomes pregnant, or someone has such severe disease that if we don't give immunotherapy, we'll lose both mom and baby, and we give that immunotherapy to her. We really want to capture that information and see how the baby and mom do so that when the next case comes along, we can say, okay, it's a few number of patients, but there's been 11 cases exposed to immunotherapy. These are the risks of using it, of not using it, and take it from there. One case at a time. You keep adding them and adding them. Next thing you know, you have 600 women in the database with cancer, and you can really look at the trends by having a larger volume of people.
Wow. Are you often finding that versus like doing treatment versus not doing treatment? Do you often find that women are adjusting the course of treatment? But like, for instance, like normally maybe they would do surgery first or chemotherapy first. Does it help when the plan is changed a little bit in terms of how the woman is treated?
It really depends on the gestational age. So if someone has breast cancer at 6 weeks of pregnancy, you really can't do chemotherapy. You prefer not to because the organs are developing. So even if maybe non-pregnant, she would have gone with chemotherapy first and then surgery. In this case, you might do this lumpectomy first or mastectomy in the first trimester so that you can get the tumor out and then let her recover for 6 weeks and then start the chemo in the second trimester. So I always defer to the oncologist and say, if the patient were not pregnant, what is the ideal treatment plan? And then we try to see if we can do it, especially if they're out of the first trimester. Most of the time we can. And if not, we have to modify things.
Okay. Now, I know you mentioned your first case was lymphoma, and she had it at 10 weeks, correct?
Mm-hmm.
Now, were you starting this registry at that point, or did you start it after that first case?
No, I was working in something else in maternal fetal medicine. I went through 4 years of my residency, did not meet a single patient with cancer who was pregnant, not one. And I remember distinctly on my oncology rotation, women having ovarian cancer in their 30s and 40s and having young children. And I thought, I am never going into oncology. This is too sad. I'm just going to do
Yeah.
like the happy baby part of OBGYN.
Yeah.
And then I was interested in medical disorders and pregnancy, and I went into maternal fetal medicine. And when that patient at 10 weeks, I didn't even meet the patient, honestly, at 10 weeks of pregnancy. I was called by risk manager of the hospital, nuclear medicine of the hospital, and oncologist before I even talked to the patient. And one,
Yeah.
two, three, they all said, if a pregnant patient, 10 weeks lymphoma, you need to do a termination. She was sitting in the radiology suite waiting for a MUGA scan, which is a nuclear medicine study of her heart, before she started adriamycin. And the radiologist said, how soon can you do her termination? I need to do this MUGA scan. Then risk management of the hospital called me within 20 minutes and said, there's a patient sitting in radiology. Her oncologist doesn't want to treat her unless she terminates. The radiologist doesn't want to do her scan unless she terminates. How soon can you do the termination? And then the oncologist called and said, hey, I have this pregnant patient. I want to do a MUGA scan. I want to do a gallium scan, and I am not treating her while she's pregnant. So when can you do the termination? And I was like, well, what does the patient want to do? So it was a Friday. I remember distinctly. I said, okay, let's wait through the weekend. I got to research this. They sent the patient home, and I called the oncologist. I said, well, if you want to do a MUGA scan to look at her heart, can't you do an ultrasound, which is an echo, and just sound waves won't hurt the pregnancy, and you can get the same heart information? And he said, no, I treat all my patients the same. MUGA is the standard of care. I want to do a MUGA scan. And I was like, well, you're not treating one patient, you're treating two. We can modify limit. Nope, this is how I treat it. This is what I need. I need the gallium scan too. So we said, okay, let's wait, do a little research. Let's think about it. Let me meet the patient on Monday. Meet the patient over the weekend. I had found that there were case reports of treating lymphoma. And well, first there was case reports saying that if you're diagnosed with Hodgkin's lymphoma when you're pregnant, I found these papers that said that if you have lymphoma when you're pregnant, 5 years later, your prognosis for Hodgkin's lymphoma is exactly the same as if you weren't pregnant. So I couldn't tell her to terminate to make her cancer better. That was step one. But because Hodgkin's lymphoma is so treatable and curable, I didn't certainly wanted her to go from 10 weeks to 37 weeks with no treatment. So the
Right.
next step was, what do we do with this cancer? The pregnancy's not making it worse, but not treating her may make it worse. So found some articles out of Mexico that looked at patients with lymphoma who had no options but to get treated first or they would have died. So they got treated. And then they reported on how these babies did, not just at birth, but long term. This is what I was looking for, the development. These
Yeah.
kids developed normally. So then I took these papers, and in the meantime, the risk management people that had called had the idea that we would all sit around a table with the ethics committee and present the risks and benefits to the couple and let them decide with the oncologist there. So um, I brought these papers there. I had met with the patient. She did not want to terminate if it wasn't required, and presented this data, went around the table, and the couple said, "We understand the risks. We would like to be treated. We don't want to terminate the pregnancy." And the partner said, "I support my wife's decision." And then the oncologist said, "I thought about it. I'm treating 2 patients instead of 1." And my division director started kicking me under the table because that's exactly what we wanted him
Yeah.
to see.
Yeah.
And he did treat her. And then my next question was, okay, she's only 10 weeks. Can we wait 2 to 3 more weeks till she's out of the first trimester without affecting her prognosis? That was question number 3. He said yes. So then we waited till she was out of the first trimester. We did an ultrasound and everything was fine. He treated her. I followed the baby on ultrasound after every treatment and, really scrutinized how everything looked. And then we delivered her and he was fine. And the oncologist said, "Well, thank you for your help. That'll never happen again." And I thought, okay, maybe it won't. We'll see. And then 3 months later, someone with melanoma was told she had to terminate before she had extensive surgery and a lymph node dissection for her melanoma. And then 3 months after that was the first patient with breast cancer who was told to terminate. And it was after that third case, I was like, okay, we need to collect these cases because we need to help OBGYNs and
Yeah.
oncologists work together to come up with a plan to treat these patients and follow these babies. And um, the other the other interesting thing that came out around that ethics committee was that somebody raised their hand and said, "Well, we know chemo causes women to be infertile. It increases the risk of infertility because it affects our ovaries. How do we know
Yeah.
that the fetus won't be infertile? What if the fetus is going to not have functioning testes or ovaries?" And I was like, "Okay, I will follow this child at least through puberty." And now I'm following him. He's, 22 years old. So, of course, he goes through normal secondary sex characteristics, and these babies go through puberty because your testes and your ovaries are dormant when you're a fetus, and
Right.
they do not appear to be affected by this chemotherapy. So
That
the registry didn't start with patient 1, it started after patient 3.
Wow, that is wild. Now when you were starting this, what did you start to notice that you're seeing more and more patients have cancer while pregnant, and specifically in breast cancer? Because I know you said the third one was breast cancer, right?
At the time, the third one was breast cancer, and, this is before social media. This is
Right.
before, websites. So it really was just patients locally who heard about the registry, whose
Right.
oncologist or OBGYN knew about it. So it was like patients were trickling in. And then I kept, looking on the internet for resources, and I found Hope for Two. I found Patty
Yes.
Murray, who was in Buffalo, who herself had breast cancer when she was pregnant, thought she was the only one ever diagnosed with cancer while pregnant, went through treatment, and then postpartum, when she was going for, postpartum, she found these 2 other women that also went through cancer treatment, thought they were the only ones going through it, did not know each other at the time to offer support, and then made the support group for women with cancer, and they matched them to other women. So then I flew to Buffalo and met with Patty and some members of that in a kitchen, um, and started collaborating. And then they would refer patients, from New York and from Buffalo. So word got around, and it was all different types of cancer. I think that as the years went on, it became dominantly breast, but in the beginning it was lymphoma, breast, melanoma, lymphoma, breast,
Right.
melanoma, and then breast, breast, started to
Now,
accumulate.
do you I was referred I found the registry through kind of Hope for Two. I found the Facebook group, and then they messaged
Yes.
me and said, "Have you talked to Dr. Cardonick yet?" And so that's kind of how I found the way. And I also signed up for Hope for Two's support network too, which is like it's an amazing resource to
Wonderful.
have. And
Agreed.
they connect women who have been in similar diagnosis, if they can, to women to try to help them through their process of going through cancer and pregnancy, treated during cancer and pregnancy. Now, in terms of termination, because I know that's like a big thing where you immediately think, a lot of women think that that's the only option initially. Are you finding that a lot of doctors are offering that first still, or they're unaware of the advances that have been made in terms of treating people while they are pregnant?
So I track that. I ask every patient when I talk to them if it was recommended to terminate, and if yes, by their oncologist or OBGYN, their family doctor, radiation surgeon, like who recommended that. And in the beginning of the registry, the first 10 years, it was 20% of doctors, all specialties recommended termination. And then I redid it 10 years later, and it's down to 12%.
Oh, great.
But
That's
just
great.
yesterday, literally just yesterday, a patient from Florida, um, I didn't talk to her directly. I talked to someone who knows her doctor who said, can you talk to this patient? Her doctors won't treat her unless she terminates. She's 10 weeks. She has rectal cancer. And the thing is, I work very closely with an a breast surgeon, a breast oncologist and a medical oncologist who are comfortable treating pregnant women with cancer. And I discuss cases with them that are the outliers.
Right.
And sometimes they recommend termination for different reasons. Someone has advanced cancer, someone really needs to start without delay, someone really has a cancer that is not going to do well without, let's say, a stem cell transplant. And most of the time they were really right. So when a doctor that I've treated 200 patients with breast cancer with says this patient needs to terminate, I take it very seriously because I know she's not saying it out of fear of not treating her. She's not
Right.
saying out of fear of dealing with cancer and pregnancy. She's saying it because she truly believes that's best for the patient. And so there is still a place in it, unfortunately, if you don't have, especially more so first trimester diagnosis is really
Yeah.
where it comes up, where you don't have the 6 weeks delay and able to start the chemo later, or you really need that immunotherapy that we have no information about. When For breast cancer, sometimes with HER2 positive patients that are really early in pregnancy, even though the initial studies showed that you can do chemotherapy first and Herceptin later, a lot of oncologists really like to give the Herceptin with the chemotherapy. So they are more likely in those cases, first trimester HER2 positive, to say, wait a minute, I don't want to wait that long to give the Herceptin, and they're more likely to recommend termination. Doesn't mean that patient always does that. Sometimes we have to compromise and say, okay, we're going to
Yeah.
do Adriamycin Cytoxan, then Taxol, and then we're going to do the Herceptin later. And the patient understands that's a little bit of modification of how she would be treated were she not pregnant. But that's how patients were treated before they started giving Herceptin together. So I would say that recommendation still exists in about 12% of cases. And it's sometimes from the OB, sometimes from the oncologist, sometimes from the surgeon.
All right. Now, when women reach out for the registry, I know we spoke about this briefly with me, where you had communicated with my oncologist with some questions. Now, is that something you standardly do? Where, I'm sure women ask you a million and one questions in regards to their treatment. So, how do you handle that aspect of being a part of this registry?
So my very first question that I asked in my fellowship when that patient was 10 weeks with lymphoma is the same question I ask now. Go back to your oncologist, or when I talk to the oncologist, how would the patient be treated if she were not pregnant? That's the number one goal that you're trying to simulate and get to. Um, so a lot of times it's interesting. In the very beginning, I would say I got more calls than I do now. In the beginning, more patients were recommended to terminate, and they were really looking for another option, and they always called. Now, sometimes Hope for Two will tell me about a patient, and I'll call them. And she's like, "Oh, no, no, no. My doctor didn't tell me to terminate. My doctor is giving me chemo. They heard this lecture, they saw this paper, and I'm totally comfortable with the treatment plan," which is wonderful. That's what we
Yeah.
wanted.
Yeah.
But the patients are then less likely to have this strong impetus to join the registry because they
Right.
think that the registry is just about learning the treatment options. The registry is really about expanding the research, looking at these babies, looking at moms, not just figuring out what to do, during the course of the pregnancy. So if a patient calls and says, I did ask my doctor how I would be treated if I wasn't pregnant, and they don't want to do that, would you talk to them? I'm always happy to talk to them,
Right.
but I don't directly call the oncologist and say, your patient told me that, you know, because I don't want to step on the oncologist's toes.
Right.
They are still the patient's doctor. They still have all the records and everything. I request those records so that I can document the receptors and the lymph nodes and try to figure out what influences how babies and moms do. But a lot of times I get those records after they've already started a treatment plan. So the doctors up front are the best ones to advise the patient right there. But I would love to talk to every oncologist before they start chemo to advise the best steroids to use. With
Right.
chemo, as you know, we like to
Yeah.
do the hydrocortisone or the methylprednisolone or prednisolone, not Decadron. I would like to tell them to use certain nausea medications, not amend. So it's funny, some oncologists are comfortable giving chemo and then they give the wrong antiemetic because they think that those medications are so much safer than chemo. And there's information we have more on Zofran than we do on amend. So there are preferences, and Decadron crosses the placenta, but those other ones do not. So even though steroids might be in the oncologist's mind safer than chemo, you want to look at all the medications that you're giving in pregnancy
Right.
and see which are the best studied. And so I would like to talk to, patients to be their own advocate, to say how would they be treated if they weren't pregnant. And I'm happy to talk to, their oncologist, if they would want to. But I have sometimes really reached out. Like I remember a patient was being undertreated, she was being underdosed, and she was not getting the right chemo. And I did email the physician and say, I'm really sorry to step on your toes, but for this patient. And, some oncologists are like, thank you for the help. And some oncologists are like, stay in your lane.
Yeah.
So I don't want to, offend anybody. I'm here
Of
as a
course.
resource if anybody, I'm happy to talk to people, but I don't outright call people because it's not always well received and they're right in front of the patient. Now, if the other thing is if an oncologist does not want to talk to me and is really pushing a patient to deliver preterm, let's say too early, or is giving her half the dose of chemo, or is encouraging termination that I don't know necessarily is is needed, and there might be other options. I do encourage the patient to have her oncologist reach out to a medical board that I work on in Europe called the Advisory Board for Cancer and Pregnancy. And then it's oncologist to OB, and the oncologist can email in, this is my case. This is what I want to do. Do you agree or have other suggestions? And then all experts from around the world, we put in our thoughts and then we generate a letter within a few days. And then the oncologist has a piece of paper with advice.
Right. Wow. I mean, that seems like a long way to get to, getting that information to the doctor, but I can understand why they would want more of a different route that way. Now, and
Hmm.
you had mentioned in regards to the weight that made me think of a question. Now, when you're pregnant, obviously, and you are going through chemotherapy, everything, has already started. And obviously, pregnant women gain weight throughout their
Hmm.
pregnancy. Are they supposed to have dose adjustments based on weight, or how does that work in terms of a
Yes,
pregnant
they are.
woman? They are.
Yes,
Okay,
they are.
interesting.
So you should have your chemotherapy based on your, most cases, I think carboplatin's different, but most chemotherapies are milligram per meter squared. That should be on your body surface area of your actual weight in pregnancy, not your ideal body weight, not your pre-pregnancy weight, not your first pregnant weight, first prenatal weight, but your weight. Now, most women, your BSA doesn't change that much as you go through pregnancy, unless women really gain a lot of weight. But I do see on chemotherapy flow sheets that I request that the BSA is written each time. So I do think that most oncologists are dosing the patient based on their body surface area at that time that they come in. And I do track that. I do
Okay.
track if a patient's undertreated or not.
I remember
I
thinking about
request the
that.
dose, is what I mean.
Right, right. I remember thinking about that in hindsight, because I know I was weighed every time I went in before
Yes,
chemotherapy, and then afterwards, I'm like, wow, I wonder if they were adjusting the dose after, like
they
if
were.
that was necessary or not.
Yeah, they
I
were.
also have a question in regards to signing up for the registry because I remember when I first was like embarking on this, it was a little bit, I was already mentally kind of like in a fog from going through everything. And I remember thinking about signing up and filling out all the paperwork, and it was kind of daunting for me personally to like think about really anything. So
Understood.
how would you recommend a woman kind of like encourage them to sign up even through that difficult time? Because I know obviously if they're coming to, they're already in this circumstance, and probably dealing with some stuff.
Yeah, I mean, you could answer that better than me in the sense that, like, because I do try to call people,
Yeah,
and I
that
sometimes I
helped.
get them at their doctor's office. Sometimes I get that they don't pick up the phone. We've tried to, so we used to mail things out. Now we've streamlined it. Patients gave feedback that if they're sitting in a doctor's office, they could just do it on their phone. So now we say
Oh, nice.
send electronic um, enrollment packets, and I just want patients to know, like, it's just reading the consent, signing it, and signing medical release forms to get your records. No one has to collect their own records. No one has to tell their doctors to send anything. We will do all of that. We just need your written permission and obviously your doctor's name and contact information. And then we'll request the oncology records, the OB records, when it gets close to your due date, the delivery records, and then every year on the baby's birth, the pediatric records. But you just sign that one time
Right.
for your registry and the medical release form. And I'll take any advice on whether like a month postpartum I should resend it. Like I don't want to bother people. I know you're going through a lot. And
Yeah.
the other thing that I think patients get confused about is Hope for Two has their own paperwork as well. So
Right.
sometimes I call patients and they're like, "Oh, I already filled it out," and then I go back to the office and it's not there, and they filled out the Hope for Two paperwork and not the registry paperwork. So the registry
Okay.
is a consent form with medical release forms, which is a little bit, different. I work so closely with Hope for Two. I talk to Julie Morlock all the time and Patty Murray, but it's different paperwork and I don't want to
Yeah.
confuse people. But any way to streamline it, I
Of
would be happy
course.
to do that. And the other thing is that if it's too much at the time of diagnosis, you're comfortable with your doctor's treatment, they're not encouraging a preterm birth, you don't need to talk to me right now or change anything, fine. Once a baby's born, it's not too late to join because I'll still follow those babies. I won't be able to have helped with your care or influence when
Right.
you deliver or steroids or things like that, no problem, but I can still follow you and your baby after the fact.
Okay,
So
that's great
people
to
have
know.
joined, when the baby's 2 years old. It's not a
Oh,
problem.
wow.
We'll still follow the babies.
Oh, that's wonderful. Yeah, I do remember once I actually got into like filling everything out, it wasn't as like, I guess, daunting as I thought it would be. I think it was just all of like the reality of what was
Sure.
happening. Um,
Understand.
Now, if you could tell if somebody was diagnosed, right, and they're listening, what would you tell them first thing to think or to do if they were pregnant while they were diagnosed with cancer?
Ask the oncologist how they would be treated if they weren't pregnant.
That's your
Period.
go-to. Okay.
That's my
Love that.
go-to. That's my go-to. Know that you're not the only person who's been
Hmm.
treated or diagnosed with cancer, and find out what the treatment plan would be if you weren't pregnant, how flexible that is. You know,
Right.
if you would be treated, every the thing is non-pregnant patients have changes in their cancer care. Me, for instance, you go in for your
Hmm.
chemotherapy, you find out your cancer low, you have to delay. If, you know, I had friends who been diagnosed and their sister's getting married. They delay their chemo. Real life happens to non-pregnant patients that delays the treatment. It doesn't always start the day the doctor wants it to, and it
Right.
doesn't always continue without delay. So there is always modifications of cancer care, but first find out what the ideal treatment would be if you weren't pregnant, and then let's see, based on gestational age and how long we need to wait and how the baby's growing and how you're feeling, what we can do with that.
Now you mentioned your own experience. Now, can you kind of remind us about what you were diagnosed with and when? Kind of give us a little idea about that.
Sure. So last year, um, I was diagnosed with rectal cancer. I had had a lot of pain on the left side of my upper thigh. I didn't really know what that was. I had no bleeding. Um, and I was dealing with it. I thought I strained my muscles at the kickboxing gym. I didn't know what it was. I went to physical therapy and just tried to figure out what it was. It did come and go, but then once I requested a standing desk and I couldn't sit anymore, I knew something was wrong. Um, And I finally had someone check me in a different way, and they found, blood on their glove when they examined me, and that kind of moved me from the physical therapy route, strained muscle, to kind of like see what's going on. So I was diagnosed with rectal cancer. I was shocked. I mean, a pretty healthy lifestyle. Not that cancer only happens to people that don't, but like
Right.
I was shocked because I didn't have the risk factors for colon cancer. I've had colonoscopies with no polyps. I don't have a family history. I don't eat red meat. Um, and I had to tell the doctor, like when they asked what medications I was taking, I mean, embarrassingly, I take like 20 supplements. So I just was kind of blown away. Um, but I have to say, in working with pregnant women with cancer, I did think I was going to get cancer one day. I kind of was waiting for that
Interesting.
shoe to drop. I didn't expect it to be rectal cancer, but I did, I was in medical school, breast cancer was 1 in 10 women. Now it's 1 in 8. I mean, I didn't
Yeah.
really think every time I talked to a patient, I felt like I dodged it, but I knew it was coming at some point. I really didn't. I wasn't as I was shocked when it happened. I was shocked that it was rectal cancer, but I can't say I wasn't expecting it for some reason.
I'm so
So,
sorry you had to go through that. I
yeah,
mean, being
you as
around
well.
cancer so much, I'm sure it's a different feeling to also be diagnosed yourself.
Yes, and it's not like I kind of knew what to expect any better than someone else, because at that point I tried to be a patient and not someone with knowledge
Right.
uh, of cancer. But I have to say that because of the registry, patients were so supportive. Like it really helped me. Patients
Yeah.
that, and as you know, if I was nauseous or not feeling well, I got great advice from all of the patients in the registry about how to handle it, and that was really wonderful for me. But and in medical school, you're taught that um, patients don't hear everything you tell them, right? And you
Right.
should encourage patients to take notes, and they're not going to hear everything. And I always thought patients were listening to me, and I tried to enunciate and let them hear what I'm saying, and then I'm the patient, and I also missed things that the doctor said. The night before my first radiation treatment, I couldn't sleep. I was so nervous. I literally thought it was gonna be like putting my finger in a socket, that I was gonna just feel zapped
Oh.
the entire time I was laying there. And I went in and I was crying and I was shaking, and my husband was waiting outside the door, and when I came back out, he's like, "What's with your face? What happened?" I said, "It didn't hurt," but I was, like, petrified. He said, "Elyce, the doctor told you 3 times it wasn't gonna hurt." So I did not
Oh.
hear that.
Yeah.
And I understand more, I repeat myself now, to patients, because you don't hear everything that somebody says. So when you hear that word cancer, it's kind of like you're in a tunnel and like nothing else gets through.
Yeah. Yeah, absolutely. I understand that completely. And with you, what going through treatment, were you still also working and treating patients?
I did work and treat patients through all of the radiation. People told me I was going to be like falling on my face, exhausted. It wasn't as bad as I thought it was going to be, really. I was not as tired as I thought I was going to be. So
Good.
I was able to work through radiation. I worked through the first treatment or 2 of chemo, and then I was like, "Wow, this nausea it's not fun being at work and, like, running to the bathroom and just being
Yeah, it's a
tired."
lot.
So once I got to the chemo, I did take off some
Good.
time.
I think that's
Yeah,
very important for also not just obviously physical, but mental too, because you need
sure.
more time to process everything and what you're going through. How are you doing now that you are through treatment and now kind of in your following up with your scans and whatnot? How are you doing mentally, and how is that impacting? Um, how is it impacting you just being around cancer so much?
So I think I tell patients with radiation now it doesn't hurt, because that was something I didn't really grasp beforehand. And I also pay more attention, I think, to the family members and caregivers, because going through that, I think in some ways it was easier as a cancer patient than it was for the children and the family members and the mom and dad.
Yeah.
Like I think my family had a hard time, my friends had a hard time, and you have to remember that even though you're going through treatment, you have tunnel vision. You got to get to the next chemo, you got to get through
Yes.
radiation. I was marking on a calendar. I had to take pills also, and I was just crossing off every day I finished those damn pills. And I
Yeah.
had a mission, whereas everyone else was just like looking at you like, what can they do? And how,
Waiting and
like just that waiting period. So really bringing the whole family, like I used to talk to the cancer patient, like probably make most eye contact with her, and I still do, but I really try to, bring the family members into the conversation because it does impact everybody.
absolutely.
Um, and I think also for people that go through similar chemo to me, I could really warn them about some of the side effects that blew me away, like oxaliplatin, cold sensitivity. I couldn't even grab like almond milk out of the refrigerator. It was
Ugh,
that, like they told
really?
me, they said, put down your apple. It's going to feel cold as soon as I start this IV. And I'm like, okay. But they were right. And, my son got me a pair of gloves to go in the refrigerator to get stuff, which was so sweet. But that was real. That was no joke. And then um, I know that doctors can't tell you about every possible side effect that would occur because, they tell you about the ones that probably occur to most people. But I did not know about this side effect, and that was something called first bite syndrome. So I was avoiding cold things the day after my first treatment, the next morning, and I literally left blueberries out to come to room temperature, and I took a bite, and I could not believe the pain that went up my jaw into my ear. I was like, "What is that?" And I thought, "Wow, I guess that was too cold." And then I just stopped eating the blueberries. I waited, and then like couple, half hour later, I tried again. It was fine. So I forgot about it. And then dinner time, I took a bite of bread, like soft, not even cold, and the same pain. And I was like, what is going on? This is the weirdest, most painful thing I've ever experienced. I'd rather not eat than experience this. And then eventually hunger takes over and you just say, okay, I'm going to eat something soft. Went to like oatmeal or something. It was fine. And then it lasted for like 2, 3 days. I'm like, that was the weirdest thing. Forget about it. Do my pills. Next treatment comes along. I don't have anything cold. First bite of the first meal after that treatment, same thing. Pain up my neck, into my ear, jaw, the most painful thing I've ever experienced. And finally, the oncologist said, yeah, that's called first bite syndrome. Happens in like
Interesting.
2% of patients. That was
Wow.
awful. That was
Now
really awful.
that's
So
gone now. Like that was only around the day of your
it was
infusion.
around for like the first 3 days of
Yeah.
every cycle. And then
Wow.
it just went away.
Oh my
So
gosh.
yeah, that was weird.
Unreal.
Really. Yeah,
Um
crazy.
Now, so I know that like part of the part of the reason for this podcast is because it's called After the Bell because I personally had seen how different the mental load was while you were going through treatment and then after when everything kind of stops because you're like you said before, like you're in this go 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 mode where you're just tunnel vision
Right.
on getting through everything, and um, then you're not. You're done. You might have had like a no evidence of disease marker. How is that different for you once you finished your treatment? Did you notice a difference, or were you able to
Oh
just
yeah.
yeah
I think it was harder. Like you
yeah
said, in your focus, I was just like marking on that calendar, get me through. And then I brought my daughter with me to ring the bell because I thought I was only getting 4 cycles of treatment.
oh no
And then they put the IV in, they're like, two left. I'm like, what do you mean?
oh,
This is the last day. And they're like, no, you have two more. We're doing six,
oh
not four. So, that was a
yeah,
setback.
I'm
But
sure.
still, then you're back in like, okay, I had to call my job, not coming back when I thought I was. I got to have 2 more cycles. But I think after it, especially rectal cancer, there's no maintenance therapy, like a year of tamoxifen, or 10 years of
Right.
tamoxifen, or a year of Herceptin. You're just done. And now you just have to bite your nails and go scan to scan. So I do
Yeah.
think it's more anxiety provoking because you're not on a treatment. You're just
Right.
praying that that treatment worked. Um, so it is
Have you
harder in
changed
some
anything
respect.
after, like in terms of your lifestyle? I know you said you were a healthy person and, take supplements and do all the things. Have you changed anything after going through your or
So,
cancer?
so I was always someone, you can ask my kids in a silly way, always celebrating the little things, the big things. Like I'm still doing that. Like I don't care how small a celebration it is. It could be the dog's birthday. It could be whatever. You celebrate the good
Yeah.
times, the happy times, because you just never know, um, when something's going to happen. I think that so in my personal and home life, I don't think I changed that much. But one thing that became very clear to me when I was going through the treatment and hearing the diagnosis was that, geez, I'm the only person working on this registry. Who's going to take this over if something happens to me? So I did change some things at work, and my partners were so understanding about it, but I really didn't want to spend any excess time doing other things that would take away from that. So, for example,
Wow.
if I'm on call, um, I have 2 days of research, that I do on my own time. So I like to not be on call the night before my research day because then I'm just gonna sleep and not get a lot out of it. And I always felt that way, and I tried to do a different call day. But once I was diagnosed, I really felt that way. Like I don't have any time to be tired. I got
Right.
to get this done before this cancer
Oh,
comes back, or I got to find someone to help me, work on it so that if I'm not here, or what I'm gonna do with all these cases. So I did eventually go to my partners and my chairman and ask not to do call anymore. And that's hard
wow.
because you work with people for 20 years. You don't want them to have to do more work.
Yeah.
Um, but it was so anxiety provoking for me thinking I'm not I'm not getting it done. I'm not,
Right.
tying it up and making it sustainable. I really am nervous about that. So I stopped doing, calls. So my work life changed, and it was a little awkward at first with your other partners because, of course, then two of my partners, had left for different reasons. So it was really putting a burden on my other partners. But thankfully, we were able to hire someone, and they're so understanding, and that's really, really worked out. So I'm really trying. I was always someone who, if you talk to my mom, she was like, "Can you just sit down and look me in the eye for 2 minutes?" I could never do one thing at a time. I was a
Yeah.
multitasker, and if I wasn't multitasking, I felt bad about it. I changed that. I do try to do one thing at a time, concentrate on it, be in the moment. Probably don't necessarily mean I sit still longer, but
Yeah.
I do try to do things and get them done because I feel like I don't know when the next time I'll get to them again, type of mentality.
Yeah. Yeah. I feel that. I mean, you have done such amazing work. And even just aside from the registry, just the way you have shared online about the registry, about cancer pregnancy, and even your own journey, I think has been such like a monumental thing for the women going through that. So I want to thank you again.
Thank
Um,
you.
Before we wrap things up, I know I asked you about like before, what would you tell a woman who was just diagnosed? But if you had to go back and tell yourself one thing before you were diagnosed that you are thinking now, what would you have told yourself?
Definitely that radiation doesn't hurt. Don't freak out about it. Um, and really, really open your eyes to what you're going to receive. You cannot imagine the kindness. I mean, you can imagine because you've been through it, but strangers, people that were on the periphery of my life, just like kind things, like just tell myself like you're not going to go through this alone, and um it's okay to let people help you. And the kindness
Yes.
of people like really just blew me away. Little things, not even big gestures, but little things, and it really made a lot. And just you know tell myself, okay. I mean, I kind of felt like I'm a list person, so I kind of felt like, okay, I'm gonna write down my eight treatment, or I thought it's time for treatments, and I figured I'm going. Like, I think that I did the same thing with, when my kids would be diagnosed with something. I was like, okay, bring it on. Tell me what I need to
Yeah.
do. Um, but I always took the emotional piece out of it with them. I was like, I can handle this. I know what medicines to do. But I never really understood or addressed, honestly, the emotional piece to them of being diagnosed with that. I was just like, okay, this doesn't scare me. I know what to do.
Yeah.
So this time between that experience and then me, I was like, okay, I have to acknowledge that there are other consequences besides medical to being diagnosed
Right.
with something, whether it's for the family members or for yourself, and address that it's okay to be depressed and to be anxious, and
Yeah,
don't ignore those feelings because, they're just going to fester if you don't address them. But
absolutely.
just tell
Yeah, I think
myself that, like, you'll get through it. Yeah. Go ahead.
absolutely. When you were saying like kind of like feel your feelings, I think that's so valid. Because I'm a similar way where you just kind of want to power through things, but it's
Hmm.
okay to have bad days and it's okay to have good days. Like that's going to happen. And if you kind of avoid those bad days, they might pile up, till like the aftermath.
Yes.
So definitely like feel your feelings. And yeah, accept help. I think that was an amazing point too, because I know a lot of people have a hard time doing that. So allowing people
Hmm.
to help and allowing them to, even if it's something small, accepting it. So again, I want to thank you so much for your time. Now, if somebody is looking to like
Thank you,
find you
Lauren.
or reach out, like how would you direct them to you or even the registry?
Sure. So website is www.cancerandpregnancy.com. The email is very similar, cancerandpregnancy@cooperhealth.edu. And if you find Hope for Two, they will also get you to me.
Perfect. Thank you so much. I really appreciate your time. You've done amazing things for the whole cancer and pregnancy world, for me, and sharing your story. So again, I really thank you for everything.
Thank you, Lauren. And I love seeing the pictures of your your cute family on
Thank you. Thank
Instagram. I
you.
love it. I love it.
My chemo babe.
Thank you. Yes.